When a diagnosis of amyloidosis is made by a positive Congo red, the pathologist's job is only half done.
Mhm.
Once you're told the patient has amyloidosis, you still need to know what type of amyloidosis it is. And the Congo red stain does not provide any information with regard to what type of amyloid. This is particularly important because it's increasingly recognized that there's a form of amyloid called wild-type TTR cardiac amyloid that used to be known as senile cardiac amyloid, but we're not using that terminology anymore. But senile cardiac amyloid, from an echocardiographic standpoint, is hard to distinguish from AL cardiac amyloid. Moreover, 25% of patients with wild-type TTR cardiac amyloid have a monoclonal gammopathy. So you can't look at a patient who has a positive echo, a positive heart biopsy, and a monoclonal protein and automatically assume this is AL amyloid. You need to know the type. And in our opinion, the best way to do that is laser capture mass spectroscopic analysis of the tissue, which will identify the protein subunit of the amyloid protein. This can be done on formalin-fixed tissue. This can be done right off a glass slide where there's amyloid. And so it's important to remember that once you have a diagnosis of amyloid, step 2 is let me confirm the type of amyloid. And although immunohistochemistry was the technique of choice years gone by, today it's identifying the proteome.